Good afternoon, everybody. My name is Devinder Ramsingh. I'm a cardiac anesthesiologist and VP for Clinical Research and Development here at Butterfly. I'm joined with my partner in crime, Peter Washishima again, who's Vice President for Clinical Implementation and Education here at Butterfly. And we're both very excited for the webinar this month on POCUS training, but the idea of looking at it from the trainee perspective. I think often, Peter, we take a look and we talk about POCUS education and how it's changing and adoption of POCUS, but it's a lot of folks like us talking to each other, right? We don't really go back and try to get direct voice from the trainees itself. So I think, great idea to kind of get this meeting out there and trying to get a different viewpoint from the folks on the ground, living it every day and experiencing it and hearing your thoughts on how training has been thus far and where do you see it going in the future. And with that, I'll just kind of ask for introductions from our panel here. Just Seth, you're up at my top left, so maybe we'll start with you.
Yeah, happy to be here. Seth White, I'm a anesthesiology resident. I'm a CA2, so I'm in my second year of clinical anesthesia at Loma Linda University in Southern California. I got interested in POCUS actually when I was an M1, believe it or not, when Dr. Ramsingh was still, I think, before his butterfly days. I was a research assistant, I think was the title. So I got an early exposure to ultrasound. I had heard about it in like a lecture when I was first there and decided I wanted to try to spend some time figuring out what ultrasound was. And so I got a very early exposure, and it's been probably really important as I've transitioned through my clinical training that 10 weeks I think I had getting to scan in the department. So
Thanks, Seth. Frederick?
Hi, so pleasure to be here. I am a fourth year medical student on the MD MBA program at UC Irvine, and my exposure to ultrasound goes back to my first year of medical school. We've got a relationship with Butterfly where all the medical students here get an ultrasound starting that first year, and I've just been hooked since I first got it. Been playing around with it a lot, and I run an NGO that uses these ultrasounds to make diagnoses for prenatal care in Ghana and Togo. So that's me.
Thanks, Frederick. Jacob?
Yeah, hey everyone, happy to be here. I'm Jacob, also a fourth year medical student at UC Irvine. I'll be applying next year into internal medicine. And my experience with POCUS really goes back to also my first year. UCI has a fantastic agreement with Butterfly where all the medical students get a handheld ultrasound. And in the very first week I got it, I drove an hour up to my parents in LA, and I got to use it on my mom, and actually recognized that she had some strange pathology that I knew wasn't normal, and was like, you should go see your GI doctor about this because I don't know what this is, but it's not normal. It turns out it was a benign liver cyst. But I think like really from there and being able to see the inside of the body and like being able to acutely pinpoint things would like just from the beginning was a game changer. And yeah, happy to talk about my experiences with everyone.
Right. Thanks, Jacob. Zach?
Hello, very excited to be here. My name's Zach. I'm a specialty registrar in acute internal medicine. I work at a little hospital called Frimley Park, which none of you will have heard of. It's in Surrey in England. I'm a relatively recent convert. I'm a postgraduate year 11 now, relatively recent convert to ultrasound after years of heavy skepticism. But in the last 2 years, it's made a huge difference to the care that I'm able to offer my patients. I've got a few really cool cases actually where a very quick, not altogether complicated ultrasound really made a difference and really helped change the trajectory of the care I was offering to a patient in a really busy, really under pressure healthcare setting. And I'm looking forward to talking about some of those experiences today.
Right. Thanks, Zach.
Awesome.
Awesome. Peter, before I just wanted to bring up one housekeeping item that Peter and I will be monitoring the chat. So feel free to throw in questions there. We'll make sure to try to answer those live. And if we don't get to your question, we'll follow up with you afterwards, but we'll try to get to everyone's questions. So feel free to use that. Peter and I will be monitoring it. Peter, Go ahead.
Yeah, I know. I was going to say the same thing from housekeeping. All of you who are chiming in, we're looking forward to having a great conversation with this crew. And really, this is designed to be for you. So any questions you have on ultrasound and medical education, or we have all little tidbits that everyone can share about their own personal work. So feel free to chime in, and we'll try to get to all of these in real time. And if not, we'll try and follow up afterwards. So with that,
Great. Let's just jump in. Like, why don't I just start off with the idea of discussing. So you guys are all in different levels of training, and you somewhere along the way got interested in point of care ultrasound. Would love to kind of for you to talk a little bit more about that, but also talk about your peers, about kind of what the landscape looks like, amongst your peers, about where sort of on the ground, how are people feeling about point of care ultrasound in terms of like its relevance, the value of its importance, how they see it, using it on as they advance and exit their training. Yeah, would love to kind of set the conversation starting with that. Maybe Jacob, do you want to kind of give some initial thoughts there? Yeah.
Absolutely. Yeah. As I mentioned earlier, I'm very fortunate to go to medical school at UCI, which I think out of like all the medical schools that I know of and friends I've talked to has the most focus and a really developed pipeline for teaching its medical students about ultrasound and the benefits of how you can use Pocus to diagnose and see pathology. We get a lot of training our first 2 years where we have these clinical foundation sessions where every Tuesday and Thursday we go in and we have a mentor or someone who's using it in the clinical setting come to the students and show them what they're doing. And usually these are focus days on like today's OB-GYN, today is, how to do a fast exam. And over the course of our preclinical training, we're already getting those clinical tidbits of what we can do. And I think that really shined like in our like third years when we reach the hospital, because now we are comfortable being able to use those point of care ultrasound devices or the official hospital ultrasounds to see what's wrong on a split basis.
So kind of interesting. That sounds like an amazing experience. And, you're in a med ed program where this is, I guess, the norm. And I assume you interact with other colleagues or med student peers who have a very different experience that they either don't get this or get this very sporadically. And I think both you and Frederick are in the similar world. I wonder, maybe Frederick, if you want to comment on this, do you get a sense from your interaction with other med student colleagues of what your world has felt differently than theirs, or how they perceive what your world is in terms of what they're getting from med education? Because there's clearly a disparity globally in terms of how there's education both for medical, undergraduate and postgraduate medical education in terms of who gets this and who doesn't.
Yeah, I mean, I think that this is reflective of the excesses that we have in America, and that we have access to all of these incredible imaging techniques that are exorbitantly expensive. And so we don't use these, the ultrasound as the incredible technology that it is. And it really, I feel like it should be first line for everything. And then, you should move on to more intensive types of scanning, MRI, CTs, et cetera. But for me, I just taught one of these CF sessions, actually. We went over diagnosing cellulitis, looking at lymph nodes. We looked at the gallbladder. We looked at it, for appendicitis, ileus. And this was all in one session. And I walked through each one of the scans with 4 different groups of students. And I shared stories too about how it's actually useful, trying to connect what we're teaching to reality, because sometimes it can seem like a chore, like you're trying to learn about something and it's you're just trying to get through the checklist, and connecting it to a story of this is actually useful in real life, I think is really valuable. So that's what I try to do when I teach those CF sessions. And we're lucky that at UCI we have this pipeline where the 3rd and 4th year students can kind of give back, and we actually help in teaching those sessions. to your question though about, how does this compare to other, medical students and residents? I've got friends that are medical students in other programs, and they have pretty much no exposure at all to ultrasound. And I'm, as a fourth year medical student doing electives, I see first year residents that I work with coming on as, it's their first year, they're working in the wards, they're working in the ICU. And here I am, I've got this ultrasound, we've got a patient, they're thinking, okay, mechanical ventilation, we're worried about pneumonia. And I'm like, oh, well, I can just see if there's B lines. And they're like, what? And it's really easy, maybe the patient's dehydrated, we're not really sure. Well, let's just see if the IVC is kissing. It's not like super sensitive, but it's a general idea, right? And so it's a different skill set, and the comfort that we have from having this education to just go and see. It's really, I think it's invaluable, and it puts us a step ahead. And I see that other residents, they're kind of like, they feel a little bit left out.
On that note, I have a question, and then Seth and Zach, I'd love to get your insights too on this, but want to, poke a little bit more there, Frederick, on the fact of here you are, at the student level, with the fund of knowledge and exposure through your training that you receive. That's not universal, that you hit across different school systems and training environments. It's sporadic, right? And then now at that next level, you're talking about the residents and the attendings. How do you work in the idea, because everyone's level of understanding of focus or adoption of focus is a little bit different. I'm curious from your viewpoints, how does that feel, and how do you navigate the idea of introducing this topic of point of care ultrasound to sort of, if we go to the traditional hierarchy of medical education, how do you expose that? And what does that, I mean, I imagine that can be some friction sometimes.
It's
And
very
yeah,
hard.
free jump.
Yeah, it's walking a tightrope, because you have to approach it from a place of humility. Especially like, I'm a fourth year medical student. I don't even have my MD. And here I am working, with these, they just got their MD, they're in their first year. And to be honest, I feel like when you first start working on the wards, it's been a couple months since you've done anything medically related. You've moved, your last few electives in medical school are not very intense in America. And so you're feeling a little bit behind. Maybe you have, you've got like step 3 coming up ahead and you're trying to study for that. And then you've got this medical student who's like making you feel even worse because he knows about ultrasound. You're like, what? So I think coming from a place of humility has been a lifesaver there, because it can definitely rub people the wrong way. But it's also, I think it's important to just generally come from that standpoint, because the reality is, even though I feel comfortable taking these scans, I'm not an emergency medicine ultrasound professional. I'm not an anesthesiologist yet, although I'm very much looking forward to being one. And so really what I do is I record the scan, and then I send it to a superior and say, what do you think? This looks like, we've got a couple, there's like 5-6 B lines. It looks like there's some pneumonia here. And then I do the full scan, not diffuse. It's more lobar, could be bacterial, but what do you think? What are your thoughts? And coming from that place of humility, I think it makes it much more approachable. And the way that Butterfly makes it so you can just send this over text, de-identified, the simplicity, it makes a world of difference.
No, it's a neat point. So you kind of incorporate the idea of like, well, let me just flag this to somebody who has sort of rank and get them to weigh in, and you're kind of just supplementing with the delivery of the data. Seems like a good strategy. Seth, any thoughts? And then Zach, we'll go to you. Maybe we'll just go the hierarchy, like, at different levels here.
Yeah, well, as a resident, I've done a handful of POCUS scans, and I'm, that next side, I have an MD, I'm taking care of patients. And even then, like, let's say I come to an attending and I'm like, hey, like, I don't think that, an induction with like a heavy slug of propofol is a great idea. Like the EF is like mildly like reduced. Like they'll look at me and be like, but we don't like how, like, and so them believing that, one, that I could like get a scan, and two, maybe that was like clinically relevant, can be hard to overcome. Attendings, as we know, like they have the ways that they do things, and even if you have this humility approach to it, it can be kind of I'll say offsetting, like they've got a certain rhythm to how they practice, and then having a learner come in that says, hey, like this could be actually like change how we do things. Depends on who you're doing it. Maybe depends if it's 3 a.m. or if it's 3 p.m. Might also make a difference. But I've definitely had a handful of those cases where I think by and large, my training environment, they've been really supportive. I mean, they're like, wow, good, I'm glad we looked, like let's do it that way or whatever. I've yet to come across one that they've been upset or like negative towards me with this additional information of having like a quick cardiac scan.
Zach, you mentioned already that you've kind of transitioned yourself even on, adopting Pocus in your journey.
It's really fascinating from a UK perspective to hear. I think about, I don't want to sound unpatriotic for a second, but about how far ahead you guys on the other side of the Atlantic are at integrating that ultrasound training so early in people's careers. The issue we've had, not to bore you guys with superfluous detail, but essentially we've had a big shift in the curricula that we use for internal medicine here in the UK, and that just came in about a couple of years ago. And ultrasound is now a mandatory competency for those of us looking to sort of finally finish our training 10 years into practice. And that's how I really got involved in it. Is someone said, well, you have to learn this, and I said, fine, I'll give this a go. And over the course of a year, I think I just became obsessed, because it was giving me that edge that in many ways I don't think I had before. And really interesting, Jacob, Frederick, to hear you guys sort of being able to go in and add something that maybe some of your senior clinicians didn't have. And in general, I find the response I've had going to the consultants that I work with and saying, hey, I've done this scan and it's given me this information that we didn't have before. The response overall has been really good. Just the other day, we had a patient who was, a severe heart failure, ejection fraction of about 15%, and we were trying to figure out how to manage them. And as my consultant came to see them, he takes a stethoscope off his neck. I said, well, actually, I've already scanned this guy. He's got an A-line pattern, no B-lines, no effusions. I think his lungs are dry. And my consultant, who doesn't know me that well yet, because he's it's a new job that I'm doing, he puts the stethoscope back around his neck and says, great, thank you for scanning him. So I think again, we're really behind in this, because we're training people who are in like postgraduate year 5 and saying that's when you're going to start using ultrasound, whereas it sounds like you guys are going to go into clinical practice as new MDs already skilled up in this. We're a little bit behind. But I think we're now seeing that a lot of our consultants are appreciating, hey, this is a skill set that we don't have. This is something that our junior colleagues are bringing to the table. And actually a lot of them now, a couple of years into this new curriculum, are saying, actually, we need to pick up these skills too. Because sort of the guys coming up behind us are picking up on stuff that actually a lot of the time we're missing. And I've had a lot of cases like that, and so many times where I've just been incredibly grateful that some of the POCUS obsessives that we've got here in the UK really push for this to be compulsory, because there's a lot of us who wouldn't have otherwise picked up that skill, where it's now completely changed the game for us. So it's just a really interesting time to be involved with this.
These are really great points and discussions as we're talking about learning a skill and training. There, we have a question from an assistant program director who's mentioning that he uses a lot of available FOAMed resources of Pocus 101, core ultrasound, and then he's teaching with an M Turbo. And Devinder, you can appreciate that. And the question he's asking is about how handhelds have changed or may be beneficial in terms of training interns and residents, in terms of how they develop their skill sets. So as you've all been using handhelds, and I assume also have had some engagements with larger based systems, maybe someone wants to comment on what the handheld might have done for your change in learning cadence.
I'm happy to jump in there. I think for me, it's the pure convenience. Now, I don't know how big the wards that you guys have across the way are, but trying to convince someone sort of, hey, to interrupt what they're doing and wheel in a big cart-based machine, it interrupts the flow of the examination. You have to move everything around in the bay to get it in there. And if you're really pushed for time, Peter, I know you work in emergency medicine. I appreciate that most of you here work in acute care. You don't always have the time to do that, and particularly if you've got a limited window in which to teach, having to interrupt just to rearrange sort of space, sometimes that time puts people off bringing the ultrasound in. Whereas certainly something I'm feeling, if I can pull something out of my pocket and show that to one of our F1 doctors, which I think is what you go first year residency, that instant ability to do that just really speeds things up. And when you need that time, being able to just instantly have a scan and instantly be teaching someone, this is what we're looking for, this is a B line, this is an A line, this is what an effusion looks like, without having to be like, I'm going to wander off for 10 minutes to go and find the cart machine wherever it is in the hospital. That's been a real game changer for me.
Yeah,
I'll quickly jump in, even though this is a violation as a POCUS program director, former POCUS director. One of the things that, and you may have all experienced in common of this, is that training becomes dependent on who's there for supervision when you have a cart. In other words, if you're working on a shift or someplace where there's an attending nearby you who can use the cart and help you learn stuff, that's wonderful. But the advantage of having a resident or an intern or a med student who has the handheld in their pocket and with the opportunity of uploading images is you can promote scanning independent of a mentor exactly at that time. And so one of the barriers, especially for us who were early on trying to run programs, is that we couldn't, those of us who were the interested parties in teaching couldn't be there 24/7, and it wasn't feasible. And having handhelds for residents interns offloaded the barrier of having to have someone there constantly versus I have a handheld I can scan and there'll be someone who will see my images, relatively briefly in an asynchronous fashion, but can then give me feedback to keep on going. And so that was a profound change when handhelds started showing up from cart-based systems, just from the educational direction point of view. And Devinder, apologize, interrupted. Keep going. Or
No,
I think Frederick, you were said.
Frederick, go ahead. Yeah.
I mean, I just wanted to point out that we work in a field where we wear pajamas to work, scrubs. It's like everything is about convenience. And there's a reason why Amazon is a, $1 trillion company. Convenience makes a world of difference. And we have no time as medical students and even less time as residents. If you have to roll like something, this scanning device, first you have to compete for it. Say, you want to get the ultrasound scanner and you're competing with regional anesthesia, right? So like the regional block team is using it. You can't take it. I mean, having a device in your pocket makes it so that you can actually do a scan in 60 seconds flat, send it to your attending, and get an opinion on it. If it's going to take you 10, 15 minutes to locate the device, roll it over, tell regional that you're taking it and where you're taking it to, there's too many hurdles. It's just not feasible. And so what Butterfly has done and what these handheld, ultrasound devices has done is it's made it so that you can actually do this. And I don't think it's ever been available in this way. The convenience makes all the difference.
I can add, I recently almost got poked with a needle by our regional team because I took the anesthesia card from them and said, I'm coming, I'll be back. We don't have quite as many handheld devices. Thankfully, we have quite a few carts, but the regional block room was closest to our pre-op holding area. We're pretty collegial. They know they can text me all those things, but it is, I take care of one patient at a time during anesthesia. There is a time crunch, obviously, but I get a little bit more time. So that barrier to not having in my pocket, we don't have the point of care devices, but so I still use a cart. I remember hearing someone say that if it's not on a cart, it'll hit the floor and then it'll break. That's definitely true in the operating room. There's too many things that just can be around. So we still use carts here. It is a barrier without a doubt, but at least I know usually where I can find one between our ORs. So.
I think on that note around barrier, that there was this, I think, a big divide, right, to talk about between handheld focus and cart-based focus. They're almost sort of two different kind of modalities. And I think with technology now getting better and better on the handheld side, now they're really blurring the lines of like how you envision handheld ultrasound now is, well, I can do everything I can on my cart system in terms of image quality and functionality. Now it's a sort of a new world. It still has, to your point, I think we're just along the side of just getting exposure to Pocus, but now layering in the technology of what handhelds can provide is something that I think it hopefully will be an accelerator for all of us to be able to try to get more folks on board with this. I mean, I think we've talked openly about the idea that there is still a mixed environment, right? Of people getting different levels of exposure, different levels of training. I'm curious just to be provocative of like, where are the common places? Like, where are the common specialties to you guys, like in the student area and in the hospital, where you do see Pocus really ramping up to become a standard of care versus the areas where you think there's value, but it's not quite gotten there. And then maybe Jacob, do you want to take a first stab at that?
Yeah, as you brought that up, a story instantly came to mind of my very first time on the UCI wards on my internal medicine rotation. I had the pleasure of working with Dr. Chow, who's one of our fantastic hospitalists here. And every day, like we would pre-round on our patients, of course, like look at all the labs, talk to the patient. And the very first time I rounded with this physician, he brought a butterfly ultrasound out of his pocket. And one of my patients was had heart failure. His fluid status was questionable, and he's like, let's just see if he's fluid overloaded. Just put some gel on, put it up to his neck, and you could tell. And I think like it is a world of difference, especially like in teaching and internal medicine, where you can show not only like get the acute diagnostic, but demonstrate to the people you're rounding with, the medical students, the residents, hey, this is what you can look for, this is what you should do. And it really condenses all of that time that you would spend previously, like finding a card or doing another test to figure out what you need, down into like a couple minutes max.
So internal medicine, the growing area.
Yeah, internal medicine. To go back to the question, internal medicine,
yeah,
as a growing area, outpatient as well, especially since cost can be prohibitive for large carts. I know I can think of one internal medicine physician who now runs a private practice who also uses a point of care ultrasound device to assist him in his practice. And I think that's starting to come up more as it gets popularized and there's more studies to kind of show like what we can do with this technology. But in internal medicine, both inpatient and outpatient, it really has a chance to revolutionize multiple aspects of medicine.
Yeah, I've seen a lot of adoption in anesthesia, and that I think maybe just UCI's program, but regional blocks are just, they're incredibly convenient to do when you have a butterfly on hand. And whether you're doing an adductor or a tap block or whatever, you don't have to go find a cart and fight for it. You just have the device on hand. What I wish is that we would see more adoption in family medicine. When I did my rotations through family medicine, I didn't see it used once. And that I think is really the reason why we don't see that is because the time crunch. They have so little time with patients that they can't even do a simple scan that may even be diagnostic for the issue they're trying to address. And that is, that's really unfortunate, and I think Butterfly is doing the best that they can. And all the Pocus ultrasounds are trying to make it more and more and more convenient, but there's going to be a threshold where we're going to see more adoption, but I don't think we're there quite yet. Maybe it's a cultural shift that has to happen. Maybe we have to give a little more time to primary care docs to actually do that kind of scanning. Internal medicine, I agree with Jacob that I've seen some more adoption, but I just would love to see more in family medicine. Like I have also done scans of my mom and my brother, diagnosed a Baker's cyst, a DVT. During COVID, I was able to get prenatal scans of my sister-in-law, who was super worried and couldn't make an appointment for like 4 weeks to see her OB-GYN. And it was just like, baby's okay, heart's beating, and she just couldn't feel the baby and was terrified. So that kind of thing where you can just immediately solve a problem, or at least start solving a problem. I'd love to see that in family medicine, but I don't think we're there yet because that convenience threshold.
Zach, I guess with regards to primary care and family medicine, it seems in the UK there's this incredible big push now with the NHS and hospitals at home. Are you seeing that there's a change in adoption, or that's been a big barrier as well in going out into the
I think it's I mean, I'm a hospitalist, so I've got no real expertise in primary care. I think there's a big divide here in the way that Pocus is being used. Certainly here in the UK, it's intensive care is really driving a lot of the use in terms of sort of the in-depth hemodynamic information that you can get from doing echoes and doing lots of more complex measurements. I think the scope for it in both internal medicine and general practice, which is what we call family medicine over here, it is not in the complex scans, but in the simple scans. And that's, from my perspective, where Pocus really gets exciting. Because I think it's not so much, and this is again where we get a lot of resistance here in the UK, is I think someone saying, oh, you're going to interrupt your workflow to go away and spend 20 minutes doing a really, really detailed scan of someone. And I don't actually think that's what you need. I don't really think that's the exciting thing about Pocus. I think for things like family medicine, but also internal medicine, the really exciting thing is the fact that you can do something that just takes a few seconds that'll give you a whole load of information that you wouldn't otherwise have. I had a lady in one of my rapid access clinics just a couple of weeks ago who presented several times to both the emergency department and her family practitioner with just some very non-specific pain in her right side. She'd been diagnosed with muscular pain. She'd been sent away with like increasing doses of opiates. And they said, oh, it's just a chronic pain issue. And I did a quick scan that took me genuinely, and I'm not exaggerating for effect here, about 10 seconds. And she had a relatively shallow sort of right-sided pleural effusion, which would otherwise not have been picked up if I hadn't put the probe on. We got her a CT scan that day, and actually they'd missed a new diagnosis of lung cancer. And I think if we can, that didn't take me 15 minutes. It didn't even prolong the consultation. It was quicker than if I'd listened to it with my stethoscope. And I think that's where Pocus is really exciting, is if we can get it into the hands of hospitalists, in the hands of family practitioners, and say, look, you can use this and it'll add 20 seconds onto your exam, but maybe one time in 10, that's going to completely change the trajectory of care. I think that is where Pocus is the wave of the future. I think that's where it's going to completely change what we're able to do. And that's what really excites me.
Yeah. And I can add to that too, because I've seen it in the similar, like I gave the story about inducing a patient. And I think that some of the resistance I've had from attending faculty or whoever is that when we do a cardiac ultrasound, a Pocus cardiac ultrasound, we're going to do an EF, we're going to see the valves, we're going to look at the aortic valve, we're going to look at the mitral valve, we're going to do this whole in-depth thing, where the beauty of it is really my BMI 45 patient that was a meth user that came in as an MVC. I want to know if the heart squeezes. Like, that's all I need to know. And I can probably get a view that, like, is the aortic valve opening? Yes. And the base of the heart is squeezing. Okay, we probably have an EF of 35% or more, right? Like, that is what I'm looking at. I don't need to know the gradient, the valve, like all of those kind of things. And so kind of a mentality shift is realizing that you don't have to get a perfect image, you don't have to be a perfect sonographer, but you can get diagnostic information very quickly that can change management.
And I think, not that I want to waffle on, but I think that's a big shift that we need to see in Pocus education, that a lot of the time when you look at the educational resources, you get the perfect apical 4 chamber, you get the perfect, parasternal long axis. And then when people go and start scanning, they're not getting those views because they're getting the imperfect views. And the big thing that my mentor did for me was say, you're not a sonographer, you're a hospitalist trying to get vital information. And if you can get a view that gives you the information that you need, that answers the simple question that you're answering, that view is sufficient. It doesn't have to be perfect. when you're asking a simple question.
I think that's the
Yes.
nail on the head, is like the question you're asking, like, right? Like we use Pocus to answer this very specific, very narrow clinical question. Is the stomach full or empty? Is the EF high or low? And I think that we get lost in the weeds and the details of being perfect because we're clinicians and we're detail oriented and we have all these things that drive us to medicine. But in this way, we have to kind of take a different approach.
All right, I have to take back what I said. I think we are past that convenience threshold. And just as a medical student, I don't have that level of knowledge that you guys have. That's so cool.
But to the point, and this is back to the conversation of even the barriers, of course, in handhelds. There's been, and Zach, you're describing how in your neck of the woods that critical care drives a lot of the Pocus adoption. You can arguably the critical care is maybe quasi-Pocus because they do a lot of advanced measurements, which whether they have any clinical value or not at the time of managing a patient, Devinder, is probably suspect versus what Seth is describing is that the eyeball works really well. But right, and so back to what you're learning, Frederick and Jacob, as students, right? You're learning how to put the probe on a patient and just get a picture and start looking at it, and then what does it mean? And for the most part, without all the fancy bells and whistles, continuous Doppler, BTIs, all the things that get added on, you already know the answer. And all those measurements do is confirm that you've already been smart enough to have an eyeball that recognizes that answer.
Yeah, Peter, your point's well taken in the sense of especially in any area of ultrasound. If you feel very proficient training by myself in echocardiography, right? You need to separate yourself from the viewpoint of that versus what you're doing for a cardiac focus exam. And you should take that same level, I think, in from the other rest of the exams that you guys have talked about. Yes, if you're taking care of a patient and you have a question, and ultrasound can help find you the answer for it, it's a win, right? It doesn't have to be a perfect image. And then and use that feedback that you've always all talked about with your cases about where it was rewarding because it gave you that information faster. Peter, hopping onto the idea of, okay, so we've talked about the landscape is changing. Frederick, you mentioned about family medicine. It's encouraging to see now that they have new training requirements around point of care ultrasound just coming out, which is great, to know that now that hopefully will move the needle. But we've already talked about, even in the sort of acute care specialties, inpatient settings, there's still variety of training and availability of that training. And now we're taking on these new areas where those folks are just trying to get exposed. There is a lack of Pocus educators. So how do you see as solutions for that? What can we do in the current landscape? And I'd love to hear from all perspectives, right? How do we remove this barrier? Is technology the win? Can you guys do peer-to-peer? Are there other types of clinicians that could be involved to help in this Pocus education journey? What have you seen, and what do you think could help work to get us to that level where we all feel we need to go? Who wants to take that on first? Frederick, just because I'm staring, I saw you nod the
Right.
nose.
Yeah. I think I can answer this at least partially. So as I said earlier, I'm teaching the CF sessions at UCI to the second year medical students as a fourth year. And so we have this system at UCI where the medical students themselves take their knowledge and they teach the younger students kind of how to do these scans. And really, I think it's a level of comfort that is being provided, and also a reminder to not be irreverent and impartial about the ultrasound, and to really recognize it as a gift and something that is incredibly useful diagnostically. And the reality is a lot of the medical students, they're not going to remember how exactly to do the scan. But the cool thing about Butterfly and the internet is that you can look it up on YouTube, or Butterfly's got amazing resources for, like, every single scan you can do on an ultrasound is on there. And they've got short little vignettes, 2 minutes. And if you need a reminder about how to measure the EPSS and get an estimated ejection fraction, 75.5 minus 2.5 per millimeter. Okay, now I know exactly what the EF is going to be, right? So, like, it's a very useful tool, but at the end of the day, you have to have that level of comfort to actually use it. So that is, I think, what's essential for medical students, is to just make them comfortable. And then it's that getting exposed to it over and over again. And I see this is done really well in regional rotations in anesthesia, where I can see the residents, they just, they are doing one block after another, after another, after another. And by the end of that rotation, they are so confident they could just knock all of them out in a couple hours. You got like 30 blocks for the day and you're out by before noon, right? But at the beginning of that rotation, maybe it's like 3 or 4 because they've got that trepidation. They're not as comfortable yet. And so I think the hurdles in medical school and among medical students is going to be providing that level of comfort to actually just try, to just go out there and try. And then the other thing is reminding them that it's actually useful, giving them stories of actually applying the ultrasound. So an example of this would be, so I had a patient in the ICU, and this was a patient that was mechanically ventilated, and we were concerned that they had pneumonia. And it was an easy, check for me to just pull out my butterfly and look for B lines, and then send that little video to my attending and say, hey, look, I think this is, we've got some B lines here. And sharing that story with the medical students, then they're excited. They're like, oh, I could be that guy. I could do that. But it's connecting it to reality sometimes that I think is missed in the education of butterfly, at least at UCI. So sorry for rambling on. I'll leave it at that.
And to add on a bit to what Frederick was saying, I think we have it really great at UCI with how much attention we put on ultrasound, reasonably so. I know throughout my time in my rotations as a 3rd year and 4th year, we'll have visiting students come and rotate with us. And sometimes like a patient will have a need that like causes for ultrasound, and the attending will like expect the student to have known that because like all of UCI students are comfortable like getting B lines for a patient that may have pneumonia. And so I have sent like UCI ultrasound materials and butterfly ultrasound materials to 4th year like rotating students as a 3rd year to show them like, hey, here's the education that like we're getting, and like you're kind of like you should like learn this not only just for like the rotation, but in the future because it's so useful. You'll be able to use this on your future patients. And kind of going back to the core question of like how can we get it out there more? I think UCI is at the top of ultrasound research and ultrasound like education. But getting it out to like schools is certainly going to be a big part of that solution, where it's more commonly known and more commonly taught, because UCI is one school out of 140 something continental MD schools alone, not even accounting DOs. I think there's a lot of like work to be done in terms of just general education so that when we move on to the later stages of our training as a resident and an attending, maybe not remembering exactly how to do it, but getting that exposure early on allows us to remember like, oh, hey, there is something for this. I might not remember exactly how to do it. Let me look it up real quick and then do it in 30 seconds to a minute if you don't remember it off the cuff.
Yeah, we have a question from another listener, and I guess as I'm
Peter, you want to? Yep.
the odd man out in emergencies, but no, I feel like I should answer this because it is acknowledging that we are the granddaddies of ultrasound. We'll raise the question, and as you're both, you're in anesthesia and internal medicine, the idea that for governance or for even POCUS development, it's been traditionally, at least in the States, Emerge or A&E, which has been that initial group. Clearly, all of you are different specialties, and your impression within your specialties of your specialties being now parts of POCUS committees or the next leaders that are really trying to spread adoption across the healthcare system versus, and we're all in our isolated worlds a bit, right? Where you do POCUS in anesthesia, you POCUS in emergency medicine on the wards in the hospital as a hospitalist. I guess internal medicine, ideally towards the outpatient clinics. So your impressions within where you've been practicing of these other specialties really rising up in terms of dictating governance or adoption?
It's a very interesting question. I mean, I'll just jump in, and I'd love to get everyone's thoughts on this. Having lived in several different health systems where, as Pocus was coming up, having a hospital-wide Pocus committee that had different specialties integrated into it. And Peter, to your point, it always starts with emergency medicine, right? Because of the fact that they are still the bulk users of Pocus in terms of just the level of trained faculty who can provide that. And I would say that, when it works well is through connectivity. One area in which the ability of everyone using sort of the same QA system to be able to, and then building confidence. I can at least tell you from my experience, getting confidence that, like colleagues in the emergency medicine department would be okay with me QAing exams and me vice versa, took time, right? We had to kind of ultimately see each other's scans, believe that we had a certain level of training to get there. But I do think, back to the question, that one, there should be something like that, a hospital system-based Pocus committee that allows for cross specialties, comes out with standards for Pocus certification across the health system, and then embracing the idea of who should be involved in that. If there's now the neat thing about it, in my eyes, is that there are several specialties now that have core Pocus as a required part of their training. And there's been people who now could be very facile at Pocus and could be their champion at a local institution that are not emergency medicine. Now, that didn't exist 10 years ago and barely existed 5 years ago. So, I think there is something that, Peter, in my eyes, I don't know if anybody in the panel has seen that yet, but it is probably coming, right? Which I think is exciting, right? The fact that now, it is becoming more universal. Zach, I'd love to get your thoughts too on this front about just sort of how is it by specialty, in your neck of the woods about, is there this urgency to try to get people to be on the same plane for QA and sort of a hospital-wide committee on Pocus?
So it's really interesting, the cultural differences here, because certainly there's a lot of work being done at the national level. Now, I appreciate we're a country here that's smaller than Texas, but at a national level for us, the Society for Acute Medicine, the intensive care societies, all of our societies that look after the specialties have very, very clear guidelines. I think because for years there was no clear guidance on what does someone who's accredited in Pocus look like, and now there are very sort of strict guidelines. You have to be accredited before you can sort of base your clinical decisions, or you can say, okay, I have this level of expertise. And what's interesting is that's all being done at a national level, but institutions really haven't caught on to that. You'll have a few sort of leads for that, or people who've managed to carve out part of their job plan to do point of care ultrasound, but no real institutional oversight of how ultrasound is being used. And I think part of that is sort of harking back to what we were talking about earlier, that so much of that is coming from junior people, it's coming from trainees, it's coming from students who are picking up these skills, and some of the more senior faculty are a little bit slower to catch on. So I think, as I said, it's a really interesting time to be involved in it, because I think, at least in the UK, what that quality assurance and governance process looks like now, I think 10 years from now, it's going to look completely different.
Peter, your thoughts on that question? Love to hear.
Looking forward to, it's really nice to hear actually that in the UK there's more governance coming down in the internal medicine sphere. That's been the challenge. What does it mean to be privileged? What does it mean to be a clinician who's not only been trained to use Pocus, they should be trained to use Pocus, but have to have a skill set where there's some competency and some guardrails about what that looks like. And so that's really great to hear that that's what's existing, because I think in the States, frankly, Zach, the country that's bigger than Texas, there's less direct governance in internal medicine currently, family medicine, about exactly what the expectations are and what the specific requirements are. We have some governing bodies, but it hasn't been a blanket policy that's come across yet. we are unfortunately out of time. And we're not close enough. We can all kind of get together afterwards and hang out. So be great if each of you would like to just say a couple words to the audience. Maybe a piece of advice or a thought about point of care, especially for all the learners or all the POCUS directors out there about, what might resonate for them to go forward and scan their brains out and take care of patients. So I'm going to start with Seth, because you're in the upper left for me, and we're going to do clockwise, and that's the way it is.
Yeah, I think we kind of harked on it a little bit, but the benefit and the beauty of POCUS is it answers a very specific and narrow question. And you realizing that you don't have to be perfect in what you're doing, but if you can get that question answered, and then having confidence in what you're seeing is kind of the two parts. So there's the image acquisition, and then there's the interpretation. But having a narrow focus in that scope of what you're trying to do with your probe is probably the most important thing that I think as you're starting to scan and continue scanning is to remember.
Frederick.
Oh, so I guess my closing thoughts would be to just get exposure. Get exposure as early as possible and get comfortable with it and just try. I was dead set on emergency medicine when I first applied to medical school, and I changed tack and picked anesthesia as a fourth year. But that decision to pursue emergency medicine made me think about UCI because it had an amazing ultrasound program, and I saw that. And so I think to get more people actually getting that early access, maybe that could be something that could, get more people on board, is having programs advertise, hey, you're gonna come out of this program with a strong understanding of ultrasound. And I think in a medical system in America where increasingly people are getting the majority of their learning online, not actually in the classroom, having an actual skill that you're going to get out of that medical school is more and more valuable every single year. So yeah, get out there, get scanning.
Jacob.
Yeah. I suppose my closing thoughts, a little bit to add on to what Frederick said. I think as we move on with AI advancing in every domain knowledge is going to become so much more important, and knowing the depth of your field is going to become so much more important, especially in developing fields like POCUS, where new things are coming out all the time and new ways to use this technology. I think in terms of advice for like fellow medical students who are getting exposure to this for the first time, I would say make an effort to not remember the specifics of what you're learning, but remember the general abilities that you're being presented, because they will come back in the future. And kind of harking back on my point on earlier, you in many things in the clinical setting, you don't need to know how to do it immediately, but as long as you know that it exists, with today's, you can learn anything on the internet, being able to look at a quick video, remember how to use M mode if you've forgotten, and then place it on a patient and see what you need to see, that will save you so much time and effort down the line.
Zach, I kept you last because I knew you were up latest from all of us, and I'm afraid you might bug out and go to bed. So here you go. Close it out.
Thank you very much. 18 months ago, when I just really got started in POCUS, I scanned the abdomen of a chap who I was about to send home with a bit of tummy pain, who turned out to have hemoperitoneum because he'd spontaneously ruptured his spleen, and he ended up having major surgery later that day. And if I hadn't scanned him, I have no idea what might have happened to him, but it could have been really bad. And that scan, first of all, changed his life, but it changed my life as well, because it made me realize that when it comes to POCUS, you do not need to be an expert. You can be someone who's been scanning for just a few weeks. But if you use it safely, and if you ask simple, like Seth said, if you're asking simple yes/no questions, you don't have to be an expert. You don't need to be a professor. You don't need to be, someone who's been scanning for years for it to make a real difference to your patients. So if you are just getting started, the next person you scan could be the person whose life you change through picking up that probe. Do not be put off by people who have all this incredible knowledge and who are really intimidating. Really, for all of that fancy stuff, it's the simple stuff that will change lives, and that's the stuff you should keep doing because that is the game changer, like I keep saying.
I can say that very long time ago when I was a registrar and I was moonlighting, one of my first experiences of Pocus out of the emergency department where I was training was about to call a code on a two-year-old resuscitation and popped a probe on the kid's heart, and it was beating and couldn't feel a pulse. And the kid now has children and his parents that I was going to tell the kid is dead are grandparents. And so again, as a registrar, an early experience, like I need to learn this. And I will say now from the other end as an educator, is that Pocus is no longer a novelty. It's no longer should I do this and when I should do this. It's you should do it, and you should do it all the time. And it changes your life as a clinician, and it changes your patients' lives in their outcomes often. And so for all of those who are learning, if you don't have the resources locally, there's lots of AI. We have Scan Lab at Butterfly. There's mentors globally who will help you out, but just start doing it. And when you start doing it, you'll change your life as a clinician. You'll change your patients' lives throughout your career. So, it's been great all having you. I'll turn it over to Vinder as the last.
That's right. No, I echo, Peter, what you said, and I appreciate the panel and just talking through the stories, right? Talking openly. I think we had a transparent conversation on the barriers, but it's worth it, right? Like anything else that's worth doing takes time and effort. And we encourage all of our listeners and thankful for you guys' stories to say, let's push through those barriers, right? Technology is helping. To your point, more and more, everything is available online to kind of help facilitate this. New AI tools and educational tools like ScanLab are coming out. And then encourage yourself to really push through and find those peer groups, right, that you guys all are doing in your own circles. And so, I think Peter and I applaud you guys for being the next up and coming generation of Pocus enthusiasts to get it to the next level. And with that, maybe we'll sign off and look forward to continuing these next month. All right. Thanks, everybody. Have a good evening.
Bye. Thank you all.
Thanks, guys.